Hi guys, thank you for joining us for tonight's webinar. Sorry it's taken a bit longer to get started than we anticipated. We'll jump straight in. So if you can keep yourselves muted throughout the duration of the webinar, that would be fantastic. If you have any questions, just chuck them in the chat box and the presenters will answer them as they're going along at the end of each of their presentations. There's also the opportunity at the end for general questions that you might have for the panel. So I'd like to start by introducing Associate Professor Richard Loy, and he will start us off for this evening.
Thank you, everyone. Again, apologies for the delay. For those of you who have heard my lectures, you know that I go really fast. Today, I'm going anaphylactic fast with a lot of adrenaline, so we're going to rush very quickly through my slides. If I can get my slides to work. Sorry. Perfect. So eczema in Australia affects 1 in 3 infants by 12 months of age. This is the Health Nut study in Victoria. East Asian infants in this study are at increased risk of eczema, and there are other studies showing African and South Asian infants are also at increased risk. And in our combined clinic, more than half of our patients that we see are non-Caucasian kids. We'll discuss a little bit more when we get to the panel, but we know that up to 20% of patients with eczema have food-induced urticaria and anaphylaxis compared to 1 to 3% of the general population. And there's food-exacerbated eczema or atopic dermatitis where you don't have urticaria anaphylaxis, but patients have a worsening of the eczema. This is IgE mediated in some of these patients where the eczema worsens within hours within minutes to a few hours of ingesting a food to non-IgE mediated reactions which can take up to days, and it causes a lot of confusion. There are studies showing that the cutaneous exposure to a defective barrier, which occurs, a skin barrier, which occurs in eczema, is a root of sensitization. But what is still unknown is whether early and or improved management of the atopic dermatitis can prevent food allergy. I use the term eczema and atopic dermatitis interchangeably. We know when we look at eczema across the clinical spectrum, if you have really no eczema or mild eczema, the risk of developing food allergy is really quite low. But if you have a severe eczema, the risk of food allergy increases. And if you treat the eczema well, there are studies suggesting that this may reduce food allergy. But again, as I said, there's a lot of research still being done. The issues, I guess, is children often present with relatively mild eczema, but while they wait for appropriate care, it can get markedly worse. I just really want to tell you that if you give appropriate care, the eczema improves rapidly. We're the problem in Western Australia. Our wait for our dermatology to see patients with eczema who are the least urgent were up to 4 years, and even urgent was over 6 months. And this project, the PCH Foundation provided funding, partly for a nurse practitioner, and also to develop a shared care model, which is very much partly what I'm going to talk about. I hope you're not getting an echo, because I'm certainly getting a bit of an echo here. Email or whoever the relevant people if you're getting an echo. And the other part, which is really important for rural and remote, is optimizing care in the community. And we often talk about right patient, right health professional at the right place, right time, and right place. So this is very much what we do. These are the KPIs. I'm really not going to go through that in the interest of time, but we have developed a triage process, and we've developed a lot of resources that I wish to talk about. So this is really saying that we've given lectures to many health professionals, and this is part of what we hope to do tonight, to engage with a very essential part of the health workforce, which is in a rural, remote area, to help our patients in that area. So Jemma and my co-lead, Roland, who you'll hear from, has certainly worked very hard to develop education resources to support GPs in referral decisions. We've got a GP for a certain period of this project, Corey, who's been involved in the update of the eczema health pathways with WAPA, and a guide has been developed for managing eczema. Again, these resources are available online through the health pathways. So this is a managing eczema in children that GPs and nurses in their practice can utilize. And we've also been working and continue to work with the National Allergy Strategy, which is a partnership between ASCIA, which are the allergist immunologists, and Allergy and Anaphylaxis Australia, which is a consumer organization to enhance education for consumers. And we've done face-to-face meetings in Albany and Broome, and webinars are continuing. So the nurse practitioner eczema clinic has been very successful. We also have a rapid eczema allergy support service, the REAS service, and you're going to hear from key members, Ingrid, on this, our dietitian. It's multidisciplinary, and it's targeting both eczema, and we know that up to 50% of these patients may have some form of food allergy if they have severe eczema. So these resources are available online, and I really don't wish to go in great detail to them, except you can get copies of this, certainly through the WAPA network, the WA Health Primary networks there. To Corey, we understand a little bit more perhaps on the business model as well when you see patients with eczema. And he gave us some understanding that through different Medicare funding arrangements, that there is more time available with appropriate Medicare codes. So when you look at perhaps just looking at the routine way of following up patients and using appropriate care plans, that you have a lot more time, which is really required for many of our patients with eczema. These are the resources that are available. So part of it is a pediatric eczema management plan that you can utilize as part of the Medicare funding, eczema resources that you can give patients that are online. Also raising awareness of your self-authority scripts, and Roland will talk more about it. When we start talking about using adequate amount of topical steroids, we still get health professionals giving a script for one tube, which is essentially 15 grams. And when you ask a young child to have adequate eczema, you'll be using a tube every few days. And if you give only one tube, it's difficult. So being aware that there are authority prescriptions available where you can give up to 10 tubes at one time. These are the e-referral pathways, health pathways. I know people hate it, like it, indifferent to it. I really hope that you will look at least at the pediatric eczema pathways. Certainly at the last talk we gave a few months ago, there were 60 health professionals accessing these health pathways before the talk, and 300 after the talk, and the numbers have persisted higher. So I really hope that these resources that you are getting are available there, and that you will look at it and hopefully find them useful. There are e-training courses available through ASCIA. They're free and they're CME points, especially many of us perhaps may be running low in our CME points during COVID. And there are information sheets that you can print out through the National Allergy Strategy websites, as well as the health pathway sites that you can give patients. And there are videos that Jemma, who's our nurse practitioner, stars in almost all these videos that you can get patients to look on how to do a bleach baths, wet dressings, and moisturizers. There are management plans that you can print out. And although we're targeting infants in this talk, eczema persists in some patients, so they don't really want to see a young infant having a bleach bath. So there are resources on the 250K website for teens and adults in terms of how to apply your moisturizers or bleach baths. And again, Jemma, our nurse practitioner, has been very much a key instigator on this and on Ask Your website. There are questions on cow's milk allergy, which Ingrid will address, but again, on the Ask Your website, there is a lot of information. The challenges are the project funding finishes, and part of what we're trying to do is ensure sustainability. So if we improve education, we should put ourselves out of a job for patients with mild, moderate eczema, so it can be managed much better in the community. But we recognize that severe anaphylaxis, severe eczema, shouldn't wait 6 months, which potentially can be happening. I really wish to thank many partner organizations. Our funding is from the PCH Foundation, but essentially all the funding came from Stan Perron, who unfortunately passed away. But very much his motto was making a difference to those in need. I need to acknowledge my colleague, Roland, GP Corey, Jemma, and you're going to hear from Ingrid. So the funding essentially gave Jemma's salary. A lot of the others in the team had just taken on the extra work, which was required. And I thank you. I may probably not take questions now, perhaps at the panel, for a couple of reasons. Running out of time, and two, I have no ability to see the chat with my poor eyesight. So I'll wait for the panel. Thank you.
Good evening, I'm Roland Brand. Thank you very much for staying up this late to listen to this presentation. I'm going to discuss atopic eczema in infants and children, including management of facial and infected eczema. And then I'm going to discuss some red flags in the first year of life, including some of the complicated eczemas and secondary infections, and then some of the syndromes that can be associated with eczemas, including immunodeficiencies. So I'm going to go through a number of cases to present this. This is a first case of a 6-month-old baby who has widespread, poorly defined dry erythematous rash on the trunk, limbs and face. The baby is scratching, irritable and not sleeping well. There is no history of symptoms of an urti, and on examination the child is afebrile and the rash appears to spare the nappy region. This is the sort of commonest presentation we see with early onset in infants with severe eczema, and the diagnosis here is atopic eczema, and you can see the characteristic flexural involvement of the limbs, torso, face, and typically sparing the nappy area. The eruption is erythematous with scales, patches and plaques, and characteristically the patches and plaques are ill-defined. The itch is severe, they're not sleeping well, and otherwise the baby's well with no fever. So I'm going to go through some of the statements here that are often not well understood in management of eczema. So which of the following of these statements are true? And the answer to this is they basically are all false, which is number 8. So children with eczema should have a bath more than twice a week. Certainly should be daily, which is fine, but we recommend short baths, 3 to 5 minutes. People often think food allergy is commonly the cause of eczema, which it isn't, and it is certainly more common with atopic eczema, but poorly controlled eczema can increase the risk of food allergies, and I'll go into that a bit more later. The next statement, topical steroids should be applied sparingly in children. This is often a myth, and that is believed, and they certainly should be used very liberally and as potent as possible to clear the eczema until it's clear and then slowly weaned off. Oral prednisolone should be used for eczema that doesn't respond to topical treatment. Again, this is quite old-fashioned treatment, and oral prednisolone for severe eczema flares used to be used more than 20 years ago, until wet dressing treatment came along, and basically wet dressing treatment replaced this. And the next statement, topical steroids should be used for 3 days at a time in young children. And this again is false. It should be used as long until the eczema clears and then weaned off slowly. Lotions recommended over ointments and cream, again, false in most cases. Ointments the first mainstay of treatment, and then creams in some situations. So this baby we just showed, it's been using Dermate cream. The eczema persists. How would you manage it? Well, normally we commonly use moderate potent topical steroid like Advantage fatty ointment once or twice daily to the affected areas under wet dressings until it clears. Usually takes a good week, and then about a week weaning off, and then reviewing the baby again in 2 weeks' time. So the wet dressings are put on for 15 minutes twice daily, followed by a moisturizer. And the PCH ED Eczema Guidelines, which you can access on this website, goes through some of the suitable moisturizers that we use, and including the ointments, which are commonly used, and then the creams are preferred more in hot and humid environments. And you have the thicker creams and the less thick creams, and there's examples of each. Then there's examples here of the type of bath oils we prefer and soap-free washes. There's also on this website a Managing Eczema Guideline in Children, which goes through some of the important points, like the bath or showers should be lukewarm and short, up less than 5 minutes. The moisturizer should be applied twice daily, and as you're weaning off the wet dressings and the topical steroid with flares, you should be substituting with regular moisturizers to help with the epidermal barrier defect, which is the main cause of eczema. And avoid overheating, avoid irritants, and then it goes through about the type of topical steroids that should be used. And so just going back again, the topical steroids for first-line treatment depends on the severity of eczema. So if you have very severe eczema with lichen simplex chronicus, prurigo nodularis, or pompholyx, for example, you need to start off with potent topical steroids such as Elufrat or Diprazone. So topical steroids always apply liberally. Once daily does improve compliance if it's difficult for patients to apply twice daily. And short bursts of potent topical steroid is always better than longer treatment with a milder preparation where it then becomes chronic. Ointments always superior in terms of hydration, efficacy, and are less likely to sting, as creams can cause contact dermatitis from preservatives. And always apply topical steroids at the first sign of a flare or re-flare until the skin feels completely normal and the eczema is completely cleared. Now, authority script should be given with eczema, and there are now streamlined authority codes where you can prescribe up to 10 tubes with repeats. And just to give you an idea, an average adult body surface area requires 30 grams of topical steroid to cover the whole surface area, and a 2-year-old child has the surface area of a quarter of that, so they will require 7.5 grams to cover the whole surface area of the body, which equates in a 2-year-old child to half a standard 15-gram tube of a potent topical steroid such as Alufrat, or medium potency such as Advartin. So, as I mentioned, potent topical steroids, commonest Alufrat, Diprozone ointment, which are betamethasone dipropionate, should be first line in lichenified discoid eczema or prurigo nodularis. So this is from the Australasian College of Dermatologists. It goes through potency, and highlighted in the yellow there, you can see the most common ones we use. Advartin fatty ointment, generally first line for most, and then more potent Alufrat, Diprozone, and in between Advartin and Alufrat and Diprozone, you have Novazone or Elicom, which is mometasone furoate. And sometimes we use very potent ones like Diprozone OV, which is betamethasone dipropionate in optimized vehicle, which comes in a 30-gram tube. Generally, 1% hydrocortisone is not very effective for most eczema unless it is extremely mild. So this goes through the wet dressing treatment steps. So after a bath, you pat the skin dry, apply the topical steroid all over where the eczema is, then apply a damp compress which is prepared, and usually clothing or jumpsuit is the easiest, and then you can, the temperature is not that important, but generally in very hot weather you'd want to use a cool damp compress, and if it's cold in winter you'd make it warm. And then you apply another layer on top, a dry layer, leave it on, time it for 15 minutes, then take it off and then apply moisturizer. In some babies or particularly more older children where compliance is a difficult problem, you can slightly vary the step. They can have a shower or bath and then come out, and then instead of drying them, put the topical steroid on wet skin and then apply a dry layer which then sticks to the skin, dry clothing, and then you can let them run around to do whatever, and then after 15 minutes take it all off and put the moisturizer on as an alternative treatment. So this baby after 2 weeks, you can see, is completely clear. So the important thing after that is then just the weaning off the topical steroid. And then there are some other issues. Sometimes you can get folliculitis, which you watch out for, and if there is folliculitis, then you need to cease the topical steroid and moisturizer to that area, or use a cream, topical steroid cream, and less greasy moisturizer. And there's a reference to a website to look at the video for wet dressing treatment. And now managing facial eczema, often facial eczema is not managed well because there's a worry about the potency of topical steroid use, and often it's only 1% hydrocortisone is used. So we tend to use quite safely Advartin fatty ointment. You can use it with wet dressing treatment as well, localized, including to eyelids and around the lips. And then afterwards apply Bactroban ointment if it's slightly infected, or if it's severely infected, we take swabs, and then for bacterial culture and sensitivity, and then sometimes may need to go on oral antibiotics. You can also use Elicon ointment for a short period, like for 1 week, and then go back to Advartin fatty ointment in more difficult cases. And even if the eczema is infected, like in this next case, this is an example of infected eczema. You can see the yellow crusting and diffuse erythematous scaling plaques throughout the face and scalp. You can use topical steroid on the infected eczema as long as the baby or child is under antibiotic cover. And in fact, there's evidence that applying topical steroid to infected eczema reduces the staph colony counts, even though antibiotic isn't used. So there's certainly no problem about it. The infection getting worse by applying topical steroid. So here again, you would use wet dressing treatment, swabs, antibiotics, and then use your Advartin and Dermis, Bactroban ointment, bleach baths often, and gentle removal and soaking of crusts. Now, there are sometimes difficulty with appreciating the severity of eczema in type 5 and type 6 skin, and this is an example of type 5 or 6 skin where it makes it even difficult to appreciate what the diagnosis is. But again, you can see they're hyperkeratotic hyperpigmented plaques which are poorly defined, and in the classic areas, often facial, upper eyelids, extensor surface of the limbs, and torso, posterior neck, classically. And this child would need to be treated aggressively with wet dressing treatment using Alifat ointment twice daily, and you'd be prescribing at least 1 tube of Alifat per day to clear this, and need 10 tubes over 7 to 10 days, and then slowly weaning it off. So this is again the summary of wet dressing treatment, making sure that you apply the steroid to all eczema areas and applying adequate amounts and prescribe streamlined authority, usually 10 tubes at a time, and then reviewing every 1 to 2 weeks to make sure the skin is cleared, and then supervising them to wean off the wet dressings, and then continuing with regular emollients and general measures for the skin. So there were a couple of questions asked prior to the webinar regarding house dust mite allergy and eczema, and also food allergy. So I made a couple of slides with this and just a few important points. House dust mite is a common airborne allergen which disrupts the epidermal barrier function, which is the mainstay of cause of atopic eczema. And it is one of many triggers for atopic dermatitis flares. But overall, when you look at studies of very strict avoidance measures with house dust mite is not generally effective in reducing the flares in atopic dermatitis, and allergen-specific immunotherapy again tends not to be very effective in atopic dermatitis. So testing for house dust mite allergy and other immune-specific IgE tests is often requested by parents, but particularly in the younger age group and in infants, it doesn't have much effect in clinical practice to improving eczema, and we need to focus much more on doing wet dressings and clearing the eczema and using regular moisturizers to prevent further increase in allergies to these things. And probably there's clinically a subgroup where it is useful to do the test, and it's mainly in over 6 years of age with difficult to control eczema, and in children with more facial involvement, because facial involvement usually indicates that there's more aeroallergens contributing to flares. Food allergy eczema, it can occur up to 30 to 40% of atopic dermatitis, but it's more common with earlier onset and more severe atopic dermatitis. It is induced and increased by impaired barrier function and poorly controlled eczema. And the most important history to indicate a food allergy is that to ask if the actual skin flares within 2 hours of ingestion, and it's usually an urticarial type eruption associated with possible GIT and respiratory symptoms. You can get eczema flares later on with food allergies, but the mechanism of this isn't very well understood, and it may in fact even be an indirect mechanism because of the urticarial eruption causing increased itch, and as a result of that, eczema flares. And serum-specific IgE tests and skin prick tests may often be false positive and may not be clinically relevant. And so it's not generally recommended as an investigation for all atopic dermatitis, only the more severe type, which are difficult to control. And food challenge is much more clinically relevant if there is a true food allergy. And exclusion diets are not recommended unless there is a true proven food allergy. And so consider investigating in severe earlier onset and very difficult to control atopic dermatitis that have gone through wet dressing treatment and maximum control of infections, etc. So the next set of slides I'm going to show is on some red flags. So some of these are severe eczema complications, and some of them are other conditions that can mimic and can be mistaken for atopic eczema. So this first one is classic impetigo, which is a superficial skin infection with Staph aureus or beta hemolytic strep. It's often asymptomatic. It may be associated or not associated with atopic eczema, but classically you see these discrete, confluent, yellow crusted lesions. with satellites, and there's also bullous variety where you get blisters with clear yellow or turbid fluid with an erythematous halo arising on normal appearing skin. This next slide is that of staphylococcal scalded skin syndrome, which is an exfoliative dermatosis which is widespread. It usually starts as a very localized staph infection, which may be of the skin or the ear, nose and throat areas. And then as a result of a particular strain of staph which secretes an exotoxin, the exotoxin then spreads hematogenously to distant skin sites, and then it causes a binding to desmoglein 1 in the stratum granulosum, which is the superficial layer of the epidermis, and then that results in sloughing of skin superficially. And characteristically, the child becomes very unwell with tender erythematous eruption of skin, which is very widespread with superficial erosions and superficial blistering, and so-called Nikolsky sign positive. When you press on the surface of the skin, you can easily disrupt the superficial layer through the stratum granulosum. This next slide is of eczema herpeticum or Kaposi's varicella-form eruption. This is rapid widespread infection with herpes simplex virus following inoculation in atopic damaged skin. It can occur with other skin disorders, often associated with fever, malaise, systemic symptoms, and characteristically you can see scattered grouped vesicles with punched out erosions and crusts which become confluent and widespread, usually involving the face, neck and trunk, and treatment is with hospital admission, swabs for both the herpes and also secondary staph infection, treating with antiviral, oral or intravenous antivirals and antibiotics against staph and secondary infection. This next case is often confused and mistaken for eczema, widespread irritable rash and severe pruritus, particularly during the night. And you can see this is scabies. Classically, you can see the burrows, which are skin-colored ridges up to 10 millimeters in length, which can be lineoserpiginous, and they often have a minute vesicle or papule at the end of the burrow. The burrow is due to the scabies mite in the stratum granulosum burrowing through, and often the female mite will leave the burrow during the night, and this causes the severe itch. And there's often 5 to 10 only scabies mites on the skin, and the rest of the eruption that causes the rash is a secondary autosensitization id eruption, which is an eczematous eruption, which needs to be treated as well as scabies. The next case is a case of tinea, which can be confused often with discoid eczema because it looks very similar, but here you can see the annular, well-demarcated appearance and peripheral papules and often pustules. There's some more pictures showing the geographic nature, polycyclic gyrate patterns, and with sharply marginated annular scaling and pustules. This is due to dermatophilic fungal infection such as Trichophyton rubrum or sometimes zoophilic Microsporum canis, and treatment involves oral antifungal agents such as griseovolvin and terbinafine. Now, this case is an important case that can be easily mistaken for severe eczema and or seborrheic dermatitis that does not respond and is of quite serious clinical significance. So this 9-month-old infant has a persistent rash of at least 2 to 3 months duration involving axilla, nappy area, scalp, and has been treated with various topical steroids, including potent ones like alifrat, in addition to combination with anti-candidal agents such as econosol. Characteristically, the lesions are red-brown with hemorrhagic papules, erosions, crusting. You can see scalp involved, axilla and nappy area. And what would you do next? So they've probably had swabs done for bacterial culture. They can have secondary bacterial infection. They may have had a short course of prednisolone and been treated for scabies. But this is a serious condition that requires referral to dermatologist and a skin biopsy. This is Langerhans cell histiocytosis. So this is a malignant process, and it is classified into two types. It can have a single organ involvement, of which the commonest organ is the bone, and the second commonest organ is skin. So it can be a malignancy that ends up being benign, where it then resolves, so-called benign self-resolving Hashimoto-Pritzker disease, or it can be a more serious multi-organ disease where skin is part of the condition, requiring chemotherapy, as it can be quite lethal. And the clinical clues are seborrheic dermatitis or atopic dermatitis in scalp that doesn't respond to conventional treatment, and severe nappy rash, which is ulcerative or erosive, with hemorrhagic, purpuric, yellow-red crusted papules, and also sometimes associated translucent rose yellowish crusted papules, and severe nail and mucosal involvement and associated systemic involvement. And the biopsy shows characteristic infiltration of Langerhans cells, and treatment depends on the extent of involvement, but if systemic, it requires referral to oncology and chemotherapy. Another condition that can be mistaken for eczema in a young infant is zinc deficiency or Acrodermatitis enteropathica. In most cases, it is not genetic. It presents on weaning of breastfed infants and also early on between weeks 4 and 10 in bottle-fed infants, but it can also be autosomal recessive genetic due to a transporter protein mutation, which carries the zinc across the enterocytes. And it presents with a triad of periacral and peri-orificial dermatitis, alopecia and diarrhea. And characteristically, the plaques are eczematous, vesicular, bullous, pustular, and erosive. And the distribution is that of the peri-orificial areas, but sparing the upper lip. So you tend to get this U-shaped or horseshoe appearance of the rash, which you can see on the face of the infant on the bottom right. And it responds very rapidly to zinc replacement. Another condition that can be mistaken for eczema and may be result in resistance to treatment is dermatitis herpetiformis, or linear IgA disease. In very young children under the age of 5, it is more common to get linear IgA disease, which in that age group is known as chronic bullous disorder of childhood. In older children, they may present in the teenage years with dermatitis herpetiformis. In both conditions, you get blisters and papules which are excoriated, and the classic site for dermatitis herpetiformis is the extensor surfaces of knees, elbows, buttocks, and scalp. With linear IgA disease in younger children, it tends to be more widespread, but characteristically involves the perigenital area, the lower abdomen, and you tend to get urticarial plaques with peripheral blistering lesions and so-called cluster of jewels or crown of pearl appearance in an annular pattern. And the diagnosis is made by biopsy, and there are characteristic histological changes, and on immunofluorescence you can distinguish between dermatitis herpetiformis and linear IgA. Linear IgA is or chronic bullous disorder of childhood, as it refers to as linear IgA deposition at the dermo-epidermal junction, whereas dermatitis herpetiformis, the IgA is in the dermal papillae in a fibrillar pattern. So now this slide is of ichthyosis vulgaris, and ichthyosis vulgaris is a hereditary disorder and is the commonest type of non-syndromic ichthyosis. Up to 1 in 100 people are born with this condition, and it usually first manifests or presents very early on by 3 months of age. and it presents with light grey scales over the extensor surfaces of the extremities and trunk, and also cheeks and forehead may be involved. And it can be often associated with atopic eczema due to filaggrin mutation, which is also occurs in Ichthyosis vulgaris. It's associated with hyperlinear palms and also keratosis pilaris. It's lifelong, and the treatment involves ongoing use of emollients, and the milder keratolytic emollients such as 10% urea cream and ammonium lactate and glycerol are more effective often in this condition. Now, there are other types of ichthyoses that can present also similarly to eczema, and one of the commonest syndromic one is Netherton syndrome. Netherton syndrome is autosomal recessive with ichthyosis and severe eczema, severe atopy. They have a high IgE, hyper-eosinophilia, and a characteristic hair shaft disorder with abnormal hair. And under the microscope, these hairs have referred to as trichohexes invaginata. And they often also have high food allergies with facial urticaria, angioedema, and they also have a characteristic skin eruption which tends to occur later on, which is called ichthyosis linearis circumflexa, where you get an erythematous exfoliative annula or polycyclic eruption with a double-edged peeling scale. And there's a specific genetic mutation, SPINK5, which can be tested for this to confirm the diagnosis. There's another condition that's coming into the realms of the immunodeficiency syndromes with severe eczema that is poorly controlled. One of them is Hyper-IgE syndrome, which is associated with recurrent infections, particularly staph, skin abscesses, pneumonia, pneumatoceles, and patients have high IgE, eosinophilia, and they characteristically have a papulopustular eruption with crusting on the scalp, face, neck, axilla, and nappy area, and they have recurrent infections, and that's a characteristic facial appearance, and it's important to make the diagnosis here. There's Wiskott-Aldrich Syndrome, another example of severe eczema, which is a fatal condition, X-linked, recessive, exclusively in males, and very rare, but presents with poorly controlled eczema and characteristically bleeding due to thrombocytopenia and abnormal platelets and recurrent bacterial, fungal, and viral infection. And there's also an increased risk of autoimmune disorders such as autoimmune hemolytic anemia, hematological malignancies. And early diagnosis is important because bone marrow and stem cell transplantation is required for these children. One needs to consider also various nutritional deficiencies with unusual types of poorly responsive eczema. So if you have a patient who has a photosensitive type distribution on the hands and feet, and a well-demarcated eruption which is associated with diarrhea and also neurological symptoms, then it could be the first sign of pellagra, which is due to niacin and tryptophan deficiency. So the red flags in the first year of life: unusual eczemas that are poorly responsive to treatment, where there's associated failure to thrive, diarrhea, or very generalized erythematous, almost erythrodermic eczema. If there's periorificial or intertriginous involvement or nappy area involvement, this is unusual, and any eczema associated with recurrent cutaneous and systemic infection. And these are red flags where you need to think about these unusual syndromes and investigate them and refer. So referrals with any eczemas is through the central referral service. We also have a PCH dermatologist that's on call via PCH switchboard. Then we have a dermatology clinical nurse specialist, Jenny Irvine, and also Jemma, who is the eczema nurse practitioner who can be contacted with severe cases that need to be seen urgently. Thank you very much.
Okay, a few questions have come through. So one of the first questions that came through is why sorbolene in a tub and not pump bottle?
Yeah, do you want to answer that, Jemma? I'll get Jemma, the nurse practitioner, to answer that.
Usually in relation to sorbolene cream versus in a tub versus in a pump, we just want to make sure that we are using a moisturiser cream, and many moisturisers that come in a pump are often a lotion, they're often more watery. So if it is definitely a moisturising cream in a pump, that's fine, and can be particularly helpful for children who have recurrent skin infections to prevent that cross-infection as opposed to using a tub. But typically otherwise with a sorbolene, we prefer a Kenkei sorbolene or a Kenkei sorbolene cream with 10% glycerin in the tub.
And just another one that came through during that presentation, where can we find the eczema management plan template 721 for GPs? Is it online?
Thank you. When you go to the WA Health Pathway site, I know some of you use it. That's available there. So it's really trying to encourage use of the Health Pathway site. The WA Primary Health Network should be able to help you. Otherwise, email us and I'm sure we can send you a copy of it.
Wonderful. Thank you guys for those questions. We'll just load up the next presentation.
Great, thanks. Hi everyone. So I'm Ingrid. I'm one of the dietitians here at PCH, and I work with the immunology team and in the eczema clinic as well. So I'm going to run through the relationship between eczema and food allergy and some of the other impacts of eczema on growth, and also talk a little bit about prevention of food allergies, particularly for the eczema babies. I'll try and not take too long so we can get back to Roland. He's got some more cases for us after this. In terms of growth, eczema can have moderate to severe eczema, if it's not well controlled, can have a significant impact on a child's growth. So increased nutritional requirements with inflammation and skin losses. These babies are often sleep disturbed as well, so they can be quite unsettled. And they might feed a lot, so they might either be poor feeders at the breast or bottle, or they might overfeed, which can prevent the introduction of solids. And also these babies often have a restricted diet, so if they have food allergy as well as eczema, they might be on a restricted diet. Or we do see lots of parents restricting diets because of the impression that food is one of the triggers of eczema. So all of these things can really impact on a child's growth and development and lead to problems down the track. So what we want to do is help these babies and children have more of a normal growth pattern by supporting them to have good eczema control and a wide variety in terms of their diet. So over the years, we've seen a bit of a shift in the way that we manage diet and eczema. So in the past, we've done sort of blanket allergy screening to see whether foods might be a trigger for the eczema, and the application of broad-based elimination diets has been quite widespread in the community, and I think it still is. We do see a lot of maternal dietary restrictions, and in the past we would have recommended the delayed introduction of common allergens, and sometimes there was recommendations to just rub a bit of food on the baby's skin and see if they react to that, and then perhaps avoid that food. So we've really moved away from this approach, and that's because of the recognition of not only the nutritional consequences of restricted diets, but the immunological consequences of rubbing food on the skin and sensitising babies, and delaying the introduction of solids and taking foods out of a child's diet. So we now only really do targeted allergy testing and promote the active introduction of allergens, even for high-risk infants, early on in their life. And that's because of that dual allergen hypothesis, which Richard mentioned before, where we look at the cutaneous exposure of food allergens. So when in a child with poorly controlled eczema, if they don't have a good skin barrier, the food allergen can get in and sensitise the baby to that food allergen, where they start producing IgE antibodies to that allergen. And then when they have that food, they can then react to that food. That's versus the oral exposure route. So if a baby has good skin barrier and the exposure that they get to the allergen is via the oral route, when they eat the food, that promotes the tolerance pathway. So we really want to try and prevent sensitisation through the skin and oral tolerance by early introduction. So the most important things here are to have a good skin barrier. Don't use any topical treatments on the skin that have food as an ingredient, because that can cause sensitisation to the allergen through the skin, and no testing of foods on the skin, because again, that's a route for sensitisation for that particular food. So the first step with babies with eczema is always to treat the skin. So if you're doing all of those things that Roland mentioned, then we don't really look at food until all of those at least basic and then extended medical treatments are done first. So when we get to the dietary triggers of eczema, as Roland mentioned, food allergy coexists with eczema into up to 40% of moderate to severe eczema. And the more severe the eczema, the more likely food allergy will be. But this also means that 60% or more of cases are not caused by food, and food allergy doesn't coexist in these babies. There's two types of allergies that can happen in babies with eczema, as with any child. So your immediate type allergies are within 2 hours, and you've got those classic immediate IgE mediated symptoms. And your child here would have a red or a green allergy action plan from Askia to manage those allergies. And then we have the delayed type of eczema, and this is the other thing that Roland was talking about. So the less well-defined pathway for a food allergen being involved in an eczema flare, where you get this eczema flare later on. So it might be 6 hours or more after they've eaten the food. Very hard to pinpoint what allergens are involved in that case. And then there are combined ones as well. So you may get an immediate reaction to a food, and then later on that's followed by an eczema flare, and that's really to do with the immune process that's going on in relation to the immediate reaction that's happened to that allergen. So cow's milk, egg and peanut are the main allergens that are involved in eczema if a baby with eczema has coexisting food allergy. And the diagnosis of food allergy in eczema is done, really, the clinical history is our main pointer here. IgE testing is less useful in eczema because children have hypersensitive skin and they produce more IgE in the serum anyway, so blood tests are less useful. And then we can do an exclusion diet and an oral food challenge. So this is our best way of seeing whether a baby really does react to a food. And that's more for if you are having negative IgE tests. So obviously if a child has obvious reactions within the 2 hours, so they've got hives and angioedema and anaphylaxis, we're not going to bother with an oral food challenge until it's the right time. But if you're looking for other dietary triggers in poorly controlled eczema, then you might do an exclusion diet and a food challenge. And then there's only a small subset of children that will actually have a flare with a food allergy. So most children who have eczema and food allergy will have the immediate type reaction, so that immediate reaction within the 2 hours of eating the food. So this is why we only do targeted allergen testing, because allergy testing only really indicates sensitization, so you really need the clinical history and or a food challenge to figure out whether they're actually reacting to a food. So there's really high positive, false positive rates to both skin prick testing and specific IgE testing in kids with eczema. And as I said, it's because children with eczema tend to produce a lot of IgE anyway, and they'll produce more IgE antibodies to particular allergens. So they can be quite hard to interpret, which is why we have the allergists on board. So when you get these, so the skin prick testing is more useful. If you can get the skin as well controlled as possible, that's when we'll go ahead and do skin prick testing in a child with eczema. And if there's a clear history that mum eats the food or the child eats the food and they get this big eczema flare, or they're getting, you know, hives and angioedema. So special request from Richard, please do not do a specific IgE to food mix, because that doesn't tell us very specific information about whether the child truly reacts and which food it is. So if you do one blood test for 5 or 6 different foods, you're not really getting a good picture of the specific allergen that they might be reacting to. And if we're getting lots of false positives, then it really creates a scenario for that parent not to give that child until they get a food challenge, which can be a long time to get into a supervised food challenge. So there's a plethora of information that parents can get hold of with regard to which foods to avoid for eczema, none of which are evidence-based. And this is where the sort of broad-based exclusion diets are sort of found by consumers, and we really need to be discouraging this approach because there's no evidence to show that this is effective in managing eczema at all. So with those past use of broad-based elimination diets, there's more evidence to show that both there's detrimental effects both nutritionally and immunologically in terms of restricting a child's diet who has eczema. So one of the main things that we worry about with broad-based elimination diets is that the safety of children can be compromised. So this is a chart review in a tertiary allergy centre where they looked at their children with moderate to severe eczema. And this is children who were presenting where the parents thought that, were worried that particular foods were causing the eczema. So the foods had been excluded from the children's diet, and when they were represented or reintroduced to the children, about 20% of them had developed a new immediate food allergy. So they previously tolerated the food. The food was taken out of their diet because the eczema was flaring. The food was reintroduced and they developed immediate food allergy. So 30% of those reactions were anaphylaxis. So they've developed a severe allergy by having the food taken out and represented. So strict elimination diets need to be really thoughtfully prescribed because they can lead to decreased oral tolerance. And there's more of this reporting of loss of tolerance to foods with elimination diets through the literature. And it really does support that theory that the continued consumption of a food allergy is really, really important to maintain oral tolerance, particularly in young children. But we're also seeing it in older children and adults who are taking food out of their diet and then putting it back in sometime later, in terms of increasing their risk of developing a more severe allergy. So if we are going to do exclusion diets in eczema, we tend to do it in 3 phases. So phase 1, you're going to optimise the skin management. If that's not working and you've done sort of your dermatology referral and all that eczema management is being done and the skin is still not under control and there's nothing sinister going on, then you might look at a food, we might look at a food elimination based on the history. So if there's certain foods that are suspected to cause that allergy, then we might do a 2 to 4 week exclusion. So in a young child, we wouldn't exclude for any more than 4 weeks, because if it's a non-IgE mediated pathway that's causing this, you would expect to see a big improvement after a couple of weeks. And we really want some nutritional supervision, particularly if we're taking things like cow's milk and egg out of the diet, which are in lots and lots of foods. A, you want to do it properly, and B, you want to make sure that that mother or that child is getting adequate nutrition. So the next phase would be checking whether there's symptom resolution. If there isn't, you would put the foods back in. If there is some resolution of symptoms, then you would look at challenging or testing that food. And that really needs to be done like with some medical supervision. So is it safe to do it at home, or does it need to be done in a more supervised setting? And that might really depend on the length of exclusion, so which we wouldn't prescribe, but sometimes we see these kids who've had a food out of their diet for about 6 months, and when you put it back in, we just want to make sure that they're not going to be one of those kids that has developed an immediate food reaction. After 2 to 4 weeks, we wouldn't expect that that would happen. So we challenge it to confirm that it's the trigger, and then if it turns out that food is involved, the monitoring is really important. So we need to figure out, A, whether the diet's nutritionally adequate, B, do they need to completely avoid the food, or is it a tolerance thing? So in a non-IgE mediated pathway, it's often a tolerance issue. So they might be able to get away with having small amounts of that food in the diet. And indeed, we think it's better to leave small amounts of allergens in the diet and manage the eczema medically to maintain tolerance to that food allergen so that they don't go on and develop an immediate, more severe type of allergy. And we would never recommend a food exclusion in mild eczema without the immediate food allergy type symptoms. So there's been many studies done on the impacts of food allergy in children, and so we know that there's significant issues with particularly taking cow's milk out. And remember that cow's milk is one of the most common allergens involved with eczema. So cow's milk contributes significant nutrients to a child's diet, and so there's a big impact of taking it out of the diet. There's also implications on feeding development. So avoidance will reduce the variety of food that a child is being offered. So if a child is on a broad-based exclusion diet where they've taken out lots of different foods, then it can have quite a long-term effect on their eating behaviour and their taste preferences. You can then get food refusal later on because the child just isn't familiar with a wide range of foods, and that can then lead to feeding difficulties, which tends to be higher in kids with food allergy because they've been on a restricted diet. So when we look at prevention, so here I'm talking about prevention of food allergy in all children, but particularly in children with eczema. So there's been a number of studies done on different time points. So we might look at allergy prevention during pregnancy, breastfeeding, infant feeding, and going to look specifically just at timing and of solids in general and to common allergens. So the evidence that we have for early introduction of common allergens, and I think this is really important for physicians in primary practice to know, because you are the first point of call for families, and they will ask you about solids introduction and about nutrition. So the evidence, the literature that's been that's available about where do people get their nutrition information from, the GP comes up first every time. So, or family and then GP. So the evidence that we have for early introduction is, so there's a number of studies, but the LEAF study is probably the highest quality that we have. So this is a controlled trial of over 600 babies that had eczema and or egg allergy. And they were recruited between 4 and 11 months. One group was randomised to early introduction of peanuts, so before the age of 1, and the other group was told to avoid peanuts until the age of 5. And the outcome was that basically if you had peanut introduced in that first year of life, that at 5 years of age you were 5 times less likely to have peanut allergy, or there was an 80% risk reduction of having peanuts introduced early. So this is high-risk babies with eczema and egg allergy. When we look at other allergens, so there's good evidence that there's a protective effect for introducing egg and peanut early, but not so much for the other allergens, and that's mainly due to a lack of evidence. There just hasn't been the number of studies, high quality studies done to tell us whether this applies for other allergens as well. However, we have an Australian consensus guideline for allergy prevention now, which brought together NH and MRC and ASCIA and other health bodies, which agreed that our advice should be that when the infant is ready, around 6 months, but not before 4 months, that foods should be introduced, that allergens should be introduced, and that there was no longer any point in recommending hydrolyzed formula for the prevention of allergy. So ASCIA has written guidelines for allergy prevention, which you can find on the ASCIA website. But practically, what does this mean? It means that we're not going to start shoving peanut in infants' mouths at 4 months of age. We're going to wait till they're ready. We're not going to introduce anything before 4 months. We give them iron-rich foods first, lots of dietary variety, make sure they're progressing with their textures, and then the allergens come in sometime in that first year. There is some evidence to show that the earlier you introduce it for the high-risk infants, so the kids with eczema and a family history of food allergy, that if you can get peanut and egg in by 8 months of age, that's going to benefit them the most. The problem, and the other thing, important thing to tell parents is that if they get a little bit of a rash around their mouth when they're eating, it's a contact reaction. If it goes away, it's a contact reaction. It's not an allergy, and they can keep giving their baby that food. So the problem with this is that your high-risk infants are going to be the infants of parents who are most worried about introducing the allergenic foods. So ASCIA has developed a guide for health professionals about what advice to give to parents about introducing peanut and other allergens to children with severe eczema or food allergy. And at the hospital here, we've converted this into a handout that you can give for families that's got an action plan on the back. So basically, it guides parents through how to introduce a food at home if they're really, really scared to do it. And it just involves rubbing a little bit of food on the inside of your child's lip, not on the outside of the skin, because we know that children with eczema will flare up if you put skin on the outside, and we don't want to sensitise them. So you wait for a few minutes, then you give them a little bit of the food, wait 15 minutes, give them a bit more, wait 15 or 30 minutes more. And if they're okay on that day, then they can keep giving that food on subsequent days and weeks and try and keep it in the diet once a week to maintain oral tolerance. So it's just a little guide so that they feel a little bit safe and they've got a bit of guidance about how to do it at home, because we do find that parents will delay the introduction of solids. The other really important thing to tell these parents is that some infants will develop allergy even though we introduce early, but the kids who have eczema are the ones who really need to do it. It's also really useful to tell them that there's actually been no reports of fatal anaphylaxis to allergen ingestion in children under 12 months of age. So it's actually safe to feed your baby at home and not to smear or rub food on their skin. So it's really good to know where to send them as well. So if you can just remember the nip allergies in the BUB website. So if you just Google nip BUB, it'll come up. And this is the consumer website that Richard mentioned that goes through eczema management. So it's got little videos on it. It goes through introducing solid foods. And it's now got little recipe cards and a recipe book about how to get each specific allergen in the diet. So that's a really good resource to let your parents know. So this is just an example of some of the specific information that it has on there. So our key messages for parents is that food is not always the trigger of eczema. Eczema predisposes a child to allergy, but it's not the other way around. So eczema doesn't cause the allergy, but poorly controlled eczema can make your child more at risk of developing allergy. And optimal skin management, early introduction of allergenic foods, and a wide variety of foods is one of the keys to preventing allergy, and that we only eliminate the food if the skin, the usual medical management of the skin is not working. And that elimination needs to be a really short time frame with a challenge period and some nutritional counselling to support the mother and the baby. So that's it from me.
No, thank you. Okay, it doesn't look like any questions came through from that one.
Okay, good.
Yep, so we'll get ready for the next presenter. You're right.
So I'm going to talk to you about some common conditions mistaken for atopic eczema and also some second-line treatments. So starting off with some second-line treatments for eczema. So we've looked at all the first-line treatments and treating with wet dressings, treating infections, etc. And then second-line treatments are more for older children generally, that after the age of 1 or 2, and then one of the first second-line treatments is phototherapy. So we would not consider this until at least 5 or 6 years of age when the child is compliant. So this is a typical narrow band phototherapy machine with the tubes you can see inside, and they stand in there. Or if with severe hand and foot dermatitis, you can use hand and foot phototherapy machines. And they're quite safe. Their tubes are set at a narrow band UVB between 311 and 313 nanometers. And the treatment times are very short. So usually starting off with 10, 15 seconds and then building up to a few minutes. And phototherapy narrowband has a peak action spectrum in inhibiting inflammatory cytokines with eczema and reducing Langerhans cells and altering antigen presentation and reduction of NK cells and causing apoptosis of T cells and keratinocytes. And this is a mechanism of action. And it clears eczema very well, and it has a very effective mechanism on itch. It requires cooperation and compliance with 3 treatments per week, and generally you would do a minimum of 3 months of treatment. Side effects are very minimal and it's very safe even with long-term treatment. And I'll mention a few other medications that we use very occasionally, and this is more commonly used in older children who have very severe chronic atopic eczema, where everything else has been tried and not successful. And in some particular groups like nodular prurigo, lichen simplex chronicus, and discoid eczema. And azathioprine is one of them. It's a purine analog and anti-metabolite, inhibits purine synthesis by disrupting RNA and DNA in lymphocytes. It is very effective but has a slow onset of action, and precautions need to be taken. Particularly, it requires close monitoring of blood count, liver function tests, and before starting, one needs to check the thyropurine methyltransferase level, as if some people have deficiency in TPMT, you cannot use the drug, and if there's a low TPMT, then you need to lower the dosage. There are lots of side effects, including long-term side effects with increased risk of malignancy, GIT side effects, increased risk of infection, pancreatitis, and generally we would not prescribe this for more than 6 to 12 months and try and get off the drug after that, and it's just to mainly break the cycle. Methotrexate, also rarely used anti-metabolite, inhibiting synthesis of DNA and RNA, thymidylate and proteins by competitively inhibiting dihydrofolate reductase. Again, it has a slow onset in action, and has numerous side effects, particularly GIT, liver, mucositis, pneumonitis, increased pigmentation, ulcerative stomatitis, and increased risk of infections, and requires regular blood monitoring. Cyclosporin used to be used a lot more than currently, and we generally avoid using it now, but it is one of the calcineurin inhibitors, and it binds to cyclophilin in lymphocytes and reduces T cell function. It has a more rapid onset of action, but it also has a more rapid rebound on cessation of the medication. And the problem with cyclosporin is it has a progressive reduction in renal function with usage, and this can be quite permanent. And it should only be used for short courses, and it requires very regular monitoring of renal function, blood pressure, and electrolytes. There's also increased risk of infections and malignancies and GIT side effects. Prednisolone, as I mentioned before, has a very limited role. In some cases, it can be useful for short duration just to break the cycle, and in some severe autosensitization reaction or insect bite reactions, for example, it can be of use. And in cases where wet dressings are very difficult to do, or in the severe non-compliance. The newest medication, which is now available and is hopefully coming on the market and PBS listed as dupilumab, and this has been used widely now worldwide, mostly in adults, but also in children over 12 years of age. It's a IgG human monoclonal antibody to interleukin-4 receptor alpha, and it inhibits the key signaling pathway, the type 2, TH type 2 signaling pathway, which involves interleukin-4 and 13 of atopic eczema. It's given subcutaneously with an initial stat dose in adults of 600 milligrams and 300 milligrams every 2 weeks, and lower dosage in children. It's quite expensive, and it's waiting PBS approval in Australia, although it is a first-line treatment in severe eczema, for example, in Germany. It's generally used for ongoing maintenance in severe eczema and has very minimal side effects so far, apart from conjunctivitis, blepharitis, and keratitis, which is the most common side effect, up to 10% of cases. And by using adequate lubrication and topical steroids around the eyelids and treating the eyelid dermatitis, the side effect can be reduced. Now I'm going to show some cases that are not so much red flags as I showed before, but cases that can mimic atopic eczema and often mistaken for atopic eczema. So the first case here is commonly seen in the first month or two in infants, and this is classic seborrheic dermatitis. Now, the difference with seborrheic dermatitis is its onset. Its usually onset is very early at birth with cradle cap or first month or two of life, and the condition improves between 3 to 6 months of age at the time period where atopic eczema starts to increase in prevalence. And there is that overlap period between 3 to 6 months of age where seborrheic dermatitis gets better and atopic dermatitis starts to develop in infants. And some, of course, have both, so it can be confusing to diagnose. But generally, seborrheic dermatitis improves. The incidence is less than atopic eczema. And one other way to tell clinically is this site, and in that seborrheic dermatitis involves the proximal flexures such as the neck, axilla, and nappy area, which atopic dermatitis tends to spare. And it's attributed to an overgrowth of Malassezia furfur yeast. And so treatment often involves a mild topical steroid in addition to reducing the yeast count of Malassezia by using a combination of hydrocortisone and clotrimazole as in hydrozole cream, or in more severe cases using the triple cream of Advanta and Iconosol silicone in equal proportions, which is compounded, and it responds quite quickly to treatment. The next slide is that of arthropod bite reactions. Often atopics and children with atopic eczema are more prone to arthropod bite reactions, and the confusion here is that the most of the rash, which is generally a papular urticarial eruption, which is on the torso and limbs or can be blistering, is in the form of an autosensitization reaction, and there are often only 1 or 2 bites, perhaps on the lower leg, and as a result of the bites you get a widespread id or autosensitization reaction. And this is very confusing because parents are often don't understand that it's only 1 or 2 bites that can then set off and trigger the rash again. And this is a situation where you may sometimes need a short course of oral prednisolone or wet dressing treatment to break the cycle. This is a case of a young child who's given adequate treatment for eczema and then may have needed a short course of Alicon ointment for 2 weeks for a severe facial eczema flare. And you can see here that there's still persistence of lesions, and it can eventually become chronic. But you can see characteristically it doesn't quite look like eczema. You can see the erythematous papules and some pustules, and there's characteristically sparing of the vermilion border, and then peri-orificial, mostly peri-oral distribution of lesions. And the diagnosis here is peri-orificial dermatitis, which is precipitated by topical Alicon. So topical Alicon is quite common to precipitate this. Advantan tends not to, so we generally try and limit the Alicon usage to about a week or so in very severe flares. And it's of unknown etiology. It's possibly a variant of rosacea, and it consists characteristically of these papules, vesicles, and pustules. And it's differentiated in older children from acne by showing no comedones. And there's central confluence and peripheral satellites, and treatment involves using 6 to 8 weeks of oral erythromycin. And without using oral antibiotics, this often doesn't clear, especially if it's been chronic. Autosensitization or id reaction, if you see quite a widespread inflammatory dermatoses with almost erythroderma, then we consider this, and this is a generalized pruritic widespread dermatosis that is secondary to release of cytokines from a primary site elsewhere. So this primary site could be either like a Tinea pedis, so you could have a fungal infection on the foot, or you could have an allergic contact dermatitis, for example, to rubber thongs on the foot, or you may have 1 or 2 arthropod bites on the leg. And this is the primary site, and then due to release of cytokines from the primary site, you get a widespread autosensitization eruption. Another classic example would be pompholyx on the hands from Tinea pedis. This is a picture or slide shows a very widespread eruption. So until the primary site is treated, it's very difficult for the widespread autosensitization eruption to clear. And it could be in the form of eczema, the autosensitization eruption, or it could look urticarial. Urticaria is another common type of eruption, which is widespread. So we always try and look for a primary site and then deal with the primary site treated in addition to treating the widespread eruption. Pityriasis versicolor, this is often mistaken for eczema. And as I mentioned before, the eczema is quite poorly defined, the lesions, and here you can see this clinically, the lesions are quite well defined and well sharply marginated. And this is an asymptomatic skin eruption only of real cosmetic consequence due to overgrowth of Malassezia furfur. It's non-contagious, it's predisposed by overheating, occurs more in tropical climates after exercise, and especially in teenagers. And the color of the lesions tends to be light brown, tan, pink in light skin, white in tan skin, and dark brown in dark skin. And scrapings can be taken from this and it's often a good idea to exclude a dermatophyte fungal infection. And with pityriasis versicolor, the scrapings often show a characteristic so-called spaghetti and meatball pattern of filamentous hyphae and yeast forms. And the treatment involves, apart from general measures and avoidance of overheating, sweating, it involves anti-yeast type topical treatments such as Selsun shampoo, ketoconazole, or Peveril foaming lotion. The next case is quite common, especially during spring, with an asymptomatic skin eruption that starts off with an initial plaque and then follows some days or weeks later with a widespread erythematous scaling papular eruption with characteristically annular scales that are peripherally attached and centrally frayed. And this is classically pityriasis rosea. This is a self-limiting condition, usually in young teenage children or adults, and it's due to reactivation or primary infection with human herpes virus 7 or 6, often seasonal, begins with a herald patch or plaque on the trunk with a colorate of scales, followed by this maculopapular plaque like a fine colorate of scale, eruption in lines of cleavage, torso and proximal limbs, with a characteristic peripherally attached and centrally frayed scale, which is fine, versus coarse with guttate psoriasis. It's asymptomatic. It can have numerous atypical presentations, which can be eczematous as well, purpuric, hemorrhagic, urticarial, or just involving flexural areas as opposed to trunk and proximal limbs, and can be difficult to diagnose. The skin biopsy findings are quite non-specific and not very helpful in diagnosis. It's mostly a clinical diagnosis, and actually very carefully looking at the lesion and seeing that particular peripheral attached scale with the central frame of the scale, which is probably the only condition where you see that typical clinical appearance. And usually it resolves spontaneously, but often in severe cases we use a course of phototherapy or erythromycin or acyclovir. Another condition which can look similar to pit rosea is pityriasis lichenoides. And this is similar in terms of the erythematous papules, but the scale is different. It has the so-called mica-like scale, and it presents in two forms. One form is the acute form, which looks like chickenpox. We get papules, vesicles, pustules, and ulcerating lesions with hemorrhagic crusts that resolve within weeks, sometimes with scarring and quite widespread. And the more common variety is the chronic variety, where you get the mica-like scale. Mica refers to a sheet of silicate minerals with nearly perfect basal cleavage, and this is what the scale actually looks like. And so here, this is another condition, mostly diagnosed clinically by the actual nature of the scale, looking at the scale clinically. But the biopsy findings in this condition tend to be more specific, and it's worth, in this condition, doing a biopsy, especially in chronic form if you're unsure of what it is, to confirm the diagnosis. And again, it's of unknown etiology, but thought to be viral, and has seasonal variation with outbreaks, and can be treated as well with phototherapy, and also tetracyclines and erythromycin is quite effective. This next one shows keratosis pilaris. Often we get referrals for eczema not responding to topical steroids, and the reason it doesn't respond is because it's not atopic eczema, it's actually this condition. And it can be confusing because there's clusters of these small keratotic papules, and often you get some erythema as well, so it's called keratosis pilaris rubra, and sometimes you get some pigmentation as well, so which refers to erythema melanosis follicularis faciae et coli, which means it's on the face and neck with features of keratosis pilaris, redness and pigmentation, usually in darker skin types. And this is a common disorder of follicular keratinization. It actually occurs to some extent in up to 30% of children, and about a third of cases persist into adulthood, and it can be quite annoying to children and parents, and especially if it's quite severe on the cheeks and shoulders, arms, thighs, buttocks. And we often have to tell them, because there is no cure, that this is just normal. This is just a normal variation, and that it can be a difficult thing for them to accept. And treatment, although we say mild keratolytic emollients, it's really just a sort of a band-aid method. It doesn't help too much, but one important thing is not to scrub the lesions as often they do, because it tends to aggravate the condition. A variant of keratosis pilaris is keratosis spinulosa, where the keratotic lesions are actually larger. In keratosis pilaris, the lesions are less than 1 millimeter in diameter, and these are 1 to 3, and they present in groups and plaques. And this is poorly responsive to any treatment at all. You could try topical moisturizers that are keratolytic and retinoids, but none of these things are very helpful in general. This condition, lichen planus, you can see characteristically the scale is completely different again. The lesions are violaceous, purple in color, but characteristically there are fine white lines known as Wickham striae that form the scale on top of the violaceous lesions, which consist of flat-topped papules, plaques, which are often polygonal. They have a characteristic site, usually the flexor areas of the wrists, lumbar region, shins, scalp, genital area, and the mouth can be involved. Now, this last case is very interesting. This condition is often mistaken for eczema, or it may be mistaken for multiple nevi. And this 8-year-old boy presents with a long-standing skin eruption thought to be eczema, never responded to any form of topical steroid, even diprazone OV ointment, but severely flares on scratching the lesions. An examination shows these erythematous but also tan-coloured and hyperpigmented lesions, and on rubbing the lesions urticate, which is the characteristic so-called Darier's sign. And this is the diagnosis here is urticaria pigmentosa. So urticaria pigmentosa is the most common type of cutaneous mast cell disorder in children. The onset is usually before 12 months of age. It's unknown cause, but there are certain mast cell mutations which cause proliferation in the skin. Most only have skin involvement, and they are benign and don't lead to systemic involvement, which is very rare, so-called mast cell leukemia. And it presents with these characteristic tan, brown, and red macules and papules and plaques, which urticate on Darier's sign or scratching the lesions. And the prognosis is good in childhood onset as opposed to adult onset, where the prognosis tends to be worse and they tend to persist. But investigations is controversial here, but generally we do a full blood count liver function tests and a mast cell tryptase level to reassure ourselves and parents that there's no systemic involvement. And treatment is mainly avoidance of trauma to the lesion, scratching, or ingestion of foods that and things that could also cause mast cell degranulation. In more severe cases, you need to warn them about certain anesthetics. If they're having a general anesthetic, certain general anesthetics can cause release of histamine from mast cells. Phototherapy has been reported to be effective, and then symptomatic treatment with topical steroids and antihistamines. Thank you very much.
Wonderful. Okay, I think a couple of questions came through again. Okay, what do you do when your PED does IgE testing for everyone with eczema and puts many straight onto a no dairy diet? Very hard to go against the only paediatrician in town.
This is for eczema.
I think it's for eczema. So if they've done testing for everyone with eczema and then puts them straight onto a no dairy diet, how do you go against the only?
I think if this occurs, I probably would suggest you refer them to a dermatologist, maybe to manage the eczema, and you probably find the dermatologist will then sort of go through the eczema management and then sort of convince the parent that it's very unlikely that the diet has much effect, which is mostly the case. But I'll also ask Richard to see what he says.
I agree. Part of what we're trying to do is not just upskilling general practitioners, we are also upskilling pediatricians as well. So this afternoon at our grand rounds, predominantly for pediatricians, we're also trying to upskill them. So it's hard, when people are set in what they do, but it's important that they acquire new skills. So, and some of these patients will have milk allergy, but many of them will not. So I can't comment about one person's way of practicing.
There's another component to that question that says, this particular clinician also uses cautoprotection as a marker in babies less than 12 months. So would the response that you've just given, Richard, still stand to that?
That's not an IgE mediated. So they're trying to look for evidence of inflammation in the gut, and the data is really not there. And we often use this to look for inflammatory bowel conditions. So no, that's not something we routinely do in our patients, either IgE mediated or non-IgE mediated.
My 2 cents worth would be that just maybe try and work with your paediatrician, go with that sort of 3 phases of elimination. So that there's not much evidence for excluding the dairy, but do a 2 to 3 week exclusion and then get the parent to put the food back in and see what happens and maintain a small amount. You kind of trying to bridge the gap then, I guess, against between 2 different opinions, but just a short-term elimination and then re-challenge is the key thing in eczema and IgE, I think, not IgE.
Okay. How would we approach a patient with underlying eczema as well as tinea condition?
Okay. Yeah, that's a good question. So often we do see tinea in eczema, and it could be in the form of tinea capitis, tinea pedis, or tinea corporis. And so the important thing is with eczema, if there's any suspicion of tinea, but always send off scrapings, and you need to send the patient to a lab that's very experienced with that. So if you suspect it in the scalp, then you need to do a hair pull test and a scraping from the scalp and good scraping from any of the lesions that look annular. And then if it's very obvious that they have tinea as well, then you often, the best thing I do is treat them with systemic agents. And then often you'll see that, like treating with oral Lamisil or Grisevolvin, that the tinea settles, and then often the eczema looks completely different, or then you know what's left over and treat the eczema. But often you have to treat both. And we all are always under the suspicion that there may be secondary tinea or some secondary infection. So always look for that and treat that.
Thank you. So we are up to the panel section of the night. So if you do have any questions, please send them through and we'll get them answered as they come through. So the next one is, what is the waiting time for review by the dermatology team or NP at PCH?
So the waiting time for dermatology at Perth Children's Hospital in relation to eczema. So we'll start with eczema. So if it is a priority one, so a baby under 12 months of age with eczema or a child with severe eczema will be seen typically within 4 to 6 weeks, and a priority 2 will be seen within 3 to 4 months. In terms of dermatology reviews for other conditions, we've certainly got a very, very long wait list. So if it's obviously it depends on the condition. If it's urgent and severe, it will be seen sooner rather than later, obviously within sort of 2 to 3 months. But for many of the other conditions that aren't as urgent, we do have a very, very long wait list of roughly 3 to 4 years. Having said that, in Roland, in Dr. Brand's presentation that highlighted the dermatology support at Perth Children's Hospital, having GPs being able to contact the dermatology registrar on call via the PCH switchboard is really helpful. So in many situations, it may actually prevent the child needing to be referred to Perth Children's Hospital. So you're certainly welcome to use that. If you've got any particular questions in relation to eczema that you want additional support for, or you're very welcome to pass my contact details on to parents, and they're very welcome to email me or call me here at Perth Children's Hospital. And I may be able to just do a telehealth consult with them, and that may prevent them needing to come to Perth.
I'll add a little bit on to that. The Children's Hospital Foundation funded all of Jemma, our nurse practitioner's salary. That stops as of October next year. So it's really, really important that what we're trying to do is upskill the appropriate health professionals and the community that many of these patients shouldn't be referred here, because if the current practice before Jemma or this program started, within probably 6 months of Jemma, if the hospital doesn't fund a position going, we'll be back to very, very, very long waits. So we're certainly very keen to continue funding at least part of Jemma's position, but that is definitely very unclear whether we will have a nurse practitioner in eczema as of end of October next year.
Okay, would a private dermatologist be an alternative option?
Yes, certainly private dermatologists would be a good option in very severe cases, and there's always urgent appointments that we have for infants with severe eczema that need urgent management. So that's probably the best option if you can't get into PCH. But we certainly prioritise severe urgent eczemas or infected eczemas privately, and also the PCH clinic.
Wonderful. Okay, so there doesn't seem to be any more questions coming through. We'll give it a couple more minutes. So send them through if you have anything that you want to ask the presenters tonight. Or if there's any comments on any of the questions that have been asked by the presenters, if they have any other comments they'd like to make. So one comment has come through. Thanks for a great update.
Okay, so it looks like there are no additional questions. Thank you so much, everyone, for joining us tonight. And again, we apologise for the technology issues we were having at the start of the evening. If you do have any additional questions, you're most welcome to email them to Kate, who will then field them to us, and we'll answer any additional questions that you have. But thanks again, and good night.